Good afternoon, everyone. Welcome back from your lunch. I think if this was an in-person conference, we'd have this sort of the inevitable lunch overrun and plates and things like that being cleared up in the background. So if it would help you sort of feel more at home, please feel free to rattle some crockery as you're listening. So this afternoon's session is on scaling up data services to meet national and global challenges. I'm Ben Gordon. I'm the Executive Director of Hubs and Data Improvement at Health Data Research UK. So we've got a great panel with me here today. And there have been a few changes for those of you that had earlier versions of the agenda. So unfortunately, a few panel members couldn't make it today. But we've got a fantastic trio. So we have Blythe Adamson, the Director of Quantitative Sciences at Flatiron, Sarah Culkin, the Head of Analytics at NHS Digital, and Adrian Jonas, the Associate Director of Data and Analytics at NICE. And you'll hear from each of those panel members shortly. They'll talk a bit about themselves and some of the work they've been doing. So in this session, we're focusing on how to make data more useful for research purposes. And as you'll have heard this morning, HDR UK's mission is to unite the UK's health data to enable discoveries that improve people's lives. And having access to and the ability to use high quality data is a key part of that. And we heard Otto and Liza talking this morning about the importance of useful data. So what I'd like is for each of you to come away from this session inspired by the work that's going on across different organizations and aware of just the huge range of different activities that fit within that scope of making data more useful. And often this requires a different way of thinking. You know, for each individual, what data quality or what useful data means varies massively. And so it's all about trade-offs and balances and what may be seen as very high quality or very useful data to one person may be next to useless for another individual, another organization, or another purpose. And at HDR UK, we've had to deal with that challenge of supporting researchers in identifying in advance whether a particular data set or group of data sets would be useful for their particular purposes. And as well as that, also building an evidence base for work that's done to improve data and understanding the most effective methods in that space. We've been tasked by the UK government to deliver the Health Data Research Hub programme, which is a government investment in improving data and supporting people to use it for research. And a key part of that is identifying the most effective means of making data more useful. And so in order to achieve this, we've developed the data utility framework, which was something that was shown earlier in the day. You may have seen the animation as part of the gateway session. And if not, I'll put the link in the chat later on, so you've got a chance to view that afterwards. And so this is a tool that aims to provide a generalizable means of, across any type of data set, helping researchers to identify in advance whether it would meet their particular needs, recognizing that huge heterogeneity in different uses. So we've developed this through interviews, surveys, workshops with users from a range of different sectors, with data custodians, and over a number of months continue to refine and improve this. We've tested it on over 40 data sets held by our health data research hubs, and we've now rolled that out as part of the gateway. And we'll be publishing on that as soon as possible. So that's one way we've worked to address that challenge of understanding and communicating what improving the data means to different people. And you'll soon hear from each of our panel members and the discussion later on about other ways of approaching that. So up next, I'd like to introduce Blythe Adamson.
Great, thank you. I'm Blythe Adamson, Director of Quantitative Sciences at Flatiron Health. And next slide, at Flatiron, the mission is to learn from the experiences of cancer patients to improve other patients' lives. And we do this through the at-scale curation of electronic medical records that cancer patients in the United States have, and we abstract them and turn them into useful research-ready data sets. But there are two big challenges in doing this. One is just creating this real-world data, or RWD, and the other is enabling users to generate evidence from that data. So real-world evidence we often call RWE. So next slide, you'll see this great tweet from David Robinson that I think will resonate with anyone who's ever worked with data, that 90% of data science is just wrangling the data, and the other 10% is complaining about it. In cancer, we have a particularly difficult challenge because so much of the clinical depth that's needed to do rigorous analysis is trapped within unstructured data fields, like the physician's notes about a visit or an image from a radiology scan, or even PDF scan of a faxed lab report with all of the important results that are needed. And the next slide, you'll see the process of curating structured and unstructured electronic medical records can be complex, but it also has to be transparent in order for users of that data to really understand the manufacturing pipeline of how it was generated. And once we've solved that data wrangling challenge, our next challenge is, like Ben said, to make that data usable and accessible and help the users understand, is this even fit for purpose to answer my research question? And the next slide, you'll see that there are lots of different types of users. We heard in earlier sessions today that it could be hospital administrators that are trying to understand whether they're delivering the highest quality of care possible, or benchmarking to other hospitals throughout the country, or it's an academic researcher who wants to compare the effectiveness of two different cancer treatments. And the way that those users assess whether or not the data is fit for their purpose can often be very different. And even within one research team, there are several different stakeholders that really matter and need different types of information to evaluate as quickly as possible whether or not the data set's going to be useful for them. So you might have a principal investigator or a research leader, stakeholder who wants to understand, is there biomarker information? But then you might have a methodologist, like a biostatistician or epidemiologist, who they might care more. Tell me more about the missingness of this data. And you'll often have a programmer, the person who's actually going to code the analysis, who needs to be able to understand structures of tables, how things link together, to understand whether or not those methods and that research question can be technically executed. So at Flatiron, you'll see in the next slide, we've come to develop many different tools to help both the diverse types of users, whether it's hospitals or researchers, and even within those teams, the different functional groups and team members that need to be equipped and to understand and evaluate the data. And so we've developed, visualizations that are interactive and allow you to do some initial cohort selection to understand, will there even be enough patient counts to be able to have the power to answer this question? A knowledge center that's like a Wikipedia of articles about how that manufacturing process of the data happens, or methodology tutorials, and a suite of R packages. One of the ways that we can really help support each other as researchers is helping us make our coding of these analyses more efficient, at the same time as being reproducible and transparent. And I think that there's a lot of opportunity for us to have open source, community built R packages, so that we can do similar analyses and build on each other's scientific work. And then lastly, as mentioned earlier in this symposium, at the end of the day, often you'd need a human to be able to talk to understand and ask questions about the data before you begin your analysis. And so that's, I think, will always be a key part. And so lastly, next slide, we've developed several values in what it takes to have transparency into the data generation process, and then as well transparency in your evidence generation process, to be able to understand, is this data fit for use to answer the research question? What is the provenance, that manufacturing pipeline, transparency into that, as well as the code for the analysis, so that we can ensure our research is valid and reproducible. So with that, just last slide, just to say thank you for including me on this panel, and really looking forward to hearing more from Sarah and Adrian.
Fantastic. Thanks very much, Blythe. And up next, then we have Sarah Culkin from NHSX.
Hi, so I'm currently head of analytics at NHSX, and so you will not be surprised that I am taking this very much as a question about what could we do to make data better to use for research and analysis. I've spent the last 15 years working in the health and care sector as an analyst in some form, and I agree with Blythe that really the key to this is trying to think about how you can be as open and transparent with the data that we hold. We are a public service. The service is paid for by taxpayers, and therefore openness and transparency about the data we held, how you can use it, what it's being used for, the decisions that it informs, I think is really, really vital. And I want to just unpick a little bit more what openness and transparency means. I suspect that sometimes people have in their head that, openness with data is simply getting a load of CSVs and putting them on the internet, and that is openness, job done. And I really want to unpick that a little bit more and think about the different things that the openness and transparency actually interact with and are important. And I've got, I guess, 4 key points here for when I think data openness needs to address. Number 1, hopefully fairly obvious, that it should be accessible. So if the data exists and it's appropriate, it should be made available and published in an appropriate form. Sometimes it's not appropriate to publish data, but if not, I think it is appropriate instead that we should be open about what data we actually do hold. And where the data is available, it should be easy to access. And that means both in terms of appropriate application and IG processes that are safe and appropriate, but also technically accessing data. Is it held in an appropriate format? Is it timely? Is it actually going to be of relevance, or is it a year out of date by the time it gets published? Number 2, the data should be coherent. So this talks to the idea of high quality data, but also you need to actually understand the data that you're looking at. So appropriate metadata, appropriate fields, and where, for example, calculated fields are included in the data, be clear about how that calculation occurred and consider publishing the method and the code to support that. Number 3, it should be straightforward to use. And this again speaks to Blythe's point about what's easy for one type of user to use is very difficult for others. So to be aware of all the different types of users of data and ensure that your data can be used by them. And then number 4, and this is perhaps a slightly stranger one, but that the data should be acted upon. And that means that you are working in an environment in which data and evidence is valued. There's data literacy in place so that decisions can be made in that way. And so I think with those four things, that's really how I want to kind of unpick better use of data. So that's me.
Brilliant. Thanks very much, Sarah. Now we have Adrian Jonas from NICE.
Hello, good afternoon from lockdown in a cold Manchester, and thank you to Ben for the introductions and opportunity to speak to you today. Yes, I'm Adrian Jonas, the Associate Director for Data Analytics at NICE, and lead the team here that provides central oversight, advice and support to NICE across data analytics, so very much in the user space. And also the transformation program here to increase the use of data in the development and evaluation of our guidance. So anyone who doesn't know NICE too well, we basically do everything from clinical guidelines to acting as the health technology assessment body for the UK. And if we could just move on to the next slide and talk briefly about the strategic change approach we're taking in NICE to increase use of data. And basically our leadership recognised that technological advances could improve our evidence base, and we shouldn't obsess on definitions of sort of real world data in the health sector, but simply the suitability of data, it'll be determined by the nature of the question that the evidence will inform. So early this year, January 2020, we produced a vision called the Statement of Intent to increase and extend the use of data in the development and evaluation of our guidance. And you can find that on our website. I'll try and see if I can post the link into the chat shortly. But crucially, in terms of scaling up national data services to meet our ambitions and improve patient outcomes, we recognised that evolution was required across the whole of this ecosystem you see on my slide, and that's where some of the initiatives NHSX is taking forward, and including Sarah herself, for instance, are absolutely so crucial to success. And then if we just move to the next slide, what we have obviously seen during the coronavirus pandemic, from my point of view, is that the world sometimes just won't wait for change. So I wanted to highlight a couple of activities here. We to ensure better use of data, we established a small task force within NICE, drawing from members across the organisation. Apologies for acronyms in this slide. Our science policy and research team, and also our more traditional evidence resources and information services team. And coming back to Blythe's point about where the data comes from, well, we almost knew something might happen in the sort of wild west of data analytics during the pandemic, like the hydroxychloroquine retraction from the Lancet based on unverifiable data. So that's where we published an interim approach to assessing the quality of evidence during the pandemic. And then, so on to the last slide. When it comes up to scaling up data services to meet future challenges, hopefully the lessons learned from this pandemic will help us. And NICE will play its part, leading on a comprehensive methods and standards programme. And we're taking the full outline of this to our public board in January. And we hope it'll give us the framework for best practice in conducting unbiased, high quality analysis of data to really inform modern clinical decision making and sort of improve patient outcomes. And we hope this will be absolutely flexible depending on the types of data, the different types of data you see, and also the applications, but ultimately enable us to continue to scale up data services to meet our future evidence needs. At that point, I'll pass back over to Ben.
Fantastic. Thanks a lot, Adrian. So I think we've got a poll coming up. Just taking advantage of the, there we go, it's just appeared on my screen. Hopefully that's appeared for all of you. And so the poll here, when we were talking about the session in advance, one of the things we talked about is a number of different sort of misconceptions or ideas that people have about improving data. And so we just wanted to see as attendees what your thoughts were on some of those misconceptions. So whether there's too much of a focus on technology. You know, the idea that you can sort of click a button or run a piece of software and, you know, your data will instantly be a lot more useful. Things like a sort of very narrow definition on of what usefulness means. So focusing on some of what I would see as kind of technical quality, things like completeness, you know, missing data, duplications, etc. And also there's a couple of options there at the bottom. Generalizability. So in some cases, an over focus on generalizability of improvements, so that things that are done to one data set or one modality won't be able to be mapped across, or perhaps the other direction, so not enough. And similar with standards. And if none of these kind of meet your thoughts, then please vote for other and let us know in the chat box. So hopefully that's given you enough time to pick one. So let's see what we think. So I think we've got quite a clear winner at the top, and I'll ask my panel members to respond in a second. I think for me, actually, in a way, the top two are kind of the same point. You know, one is that the top one with 39% of the vote is that there's not enough of a focus on people, and the one below that with 36% is there's too much of a focus on kind of tools and software. So in a way, you know, you could almost add those two together as being part of the same point. Or at least that's my thought on it. Blythe, Sarah, and Adrian, what do you think? Any surprises there?
I think, Ben, I'll come in if that's okay with Sarah and Blythe, and just say that in terms of cultural change, those that have worked with NICE in the past will understand when it comes to evidence-based decision making, it's not necessarily Adrian Jonas at the committee stage. It's an independent committee made up of lay members, clinicians from all walks and forms of life. And that's where the cultural change for us will have to come. Now, when we went out for consultation with the statement of intent I alluded to in my brief pitch, there was tremendous amounts of positivity from all different stakeholders. But that's where they also came back with, well, this is all well and good in terms of an ambition, but until you have the methods and standards in place, you'll never make that cultural change in terms of acceptance. So that's where I think it's quite easy to sort of just simplify to cultural change, but we then need to think about all the things underpinning that in terms of, for instance, I mentioned Sarah's work on people, if people recall the pillar on skills in my slide, and professionalisation of analytics and data science across the NHS, for instance. Thoughts from Blythe or Sarah?
So thank you, Adrian, for the plug there. I completely agree that professionalisation is very important when it comes to cultural change. So I'm quite pleased to see this as so high up, because yeah, I think it's a huge area, and I think wrapped up in cultural change, there's so many different things. So there is actually the people who collect the data, and they're linked to the people that use the data. That needs to be as short as possible. Often it is not, and therefore there's no real impetus and any particular reason to collect good quality data if you don't see any value of it from it yourself. Then as you sort of rise up the different layers of seniority, actually as you become more senior as an analyst, while you may have had really excellent technical training, then becomes a whole other question around, do you have the necessary leadership specific skills in a data environment to affect influence and communicate effectively? These are things that perhaps aren't necessarily focused on, but are really vital if you want to change the culture, perhaps in more senior management, and be able to get across the point that there is a need to engage with evidence and data as your kind of your crude oil, to use an example. You need to have the right people in place to be able to refine that oil and then use it accordingly.
Absolutely. I agree with all of those points. I've seen before coming to Flatiron many situations where teams thought that they would be able to be successful, just having a bunch of, physicians working together. They've got the best ideas ever. But then, they're talking down to software engineers to, telling them, so this is what we need. But what gets delivered back to them is not what they imagined or understood. But then I've also seen the opposite flip side of that coin, where you've just got a room full of brilliant machine learning scientists that have no clinical expertise at all and can't get the time of day from physicians that know what would actually be meaningful, or access to patients, but sit in the room and develop the coolest tech, but it's not useful or meaningful at all. And so, I think that culturally creating spaces where, you can gather a diverse set of backgrounds around one table, where a physician has the same, voice and authority as a software engineer, as a clinical abstractor, as a patient, so that they can work together as a team in both, developing a data set in a way that it is meaningful and designing a study where the results are going to be meaningful. Otherwise, if we give all of the power to one group and don't really respect the different backgrounds that we bring, we're missing out.
Brilliant. Thanks, everyone. So we've had a few questions coming through in the chat. And I'm going to kind of roll a couple of them together. So we had a question quite early on in the session about the approach to transparency. And we've had another question following up that about whether we're starting to see researchers using more open practices, for example, reuse, and the sort of fair, findable, accessible, interoperable, and reusable principles came up earlier in the day. So I'm interested to hear from all of you on transparency, how we should approach that, and if you're seeing any changes in that recently. So let's start in the order of the presentation. So Blythe, what are your thoughts on this?
Absolutely. It's so important so that we can, replicate each other's work. I mean, humans make mistakes. We make mistakes coding our analyses. We make mistakes in maybe not even choosing the right methods that are most appropriate. Some, I think, creative ways that I've seen recently of how people are able to get around this. Also with emphasizing pre-specification. What you're going to do in the analysis before you dive in and start p-hacking and just looking for things that are really interesting. One of the things that the academic researchers that use Flatiron data participate in is a platform where every single professor who uses this data set puts forth a concept proposal, with the brief methods that they're going to use. And when it's approved and they get access to the data set, that concept proposal is then visible to every other researcher that has access to the same data set. So they have the ability to see, okay, someone's already answering this question. The paper may not be published yet, but at least I know someone's working on it. And either I don't have to do it now, or we could work together and I could do it a different way. And it also creates an accountability that, I saw that you published a paper, but that wasn't what your hypothesis was that you were testing within a smaller group. And I think that there is still a lot of work to do to figure out, do we make platforms like that fully public in a competitive grant-seeking environment where many of these researchers are trying to have a competitive edge? in securing funding to do their work. And so I think that there's an exciting opportunity for pre-specification and transparency of what you're planning to be working on for researchers to work together seamlessly.
Thanks, Beth. Sarah.
Thank you. Again, to build on many of the things that Blythe has said, absolutely, working in the open, I think, is key to this. And something we're trying to do in NHSX is to actively code in the open. So rather than just we get to the end of a piece of work, here's the code, actually do it as we go along, so that, again, you can see that that work is in train and you can get feedback from a community as you go. And we would like to get to the point where this is common practice, so that before you start a piece of work, you can see, as you say, what's gone before. And while we talk an awful lot about the necessity of sharing code in order to work in the open, I would almost say that that's a secondary step to being open and interoperable. And the first step should actually have been to use someone else's code first, so that you've actually experienced what that feels like, and you've gone to the community first before starting from scratch on something. The other thing that we're doing in NHSX in terms of trying to make data more accessible is, rather than necessarily trying to collate data into data lakes or anything like that, simply some sort of health data search engine. So we've got a data lens project that we've just kicked off, which is looking to see if it is feasible to actually sit on top of all the different data sources that exist in different ALBs and different organizations, and actually just have some sort of search engine so that you can at least in one place be aware of the different data that's held in other places.
Thanks, Sarah. And Adrian.
Yes, Ben. Can't disagree too much with what Blythe and Sarah have already touched on. Transparency, reproducibility, absolutely vital. And I think obviously when we're talking about data to evidence, everything in terms of what NICE considers at the evidence point for decision making is then made transparently available. And we're having conversations with Lancet Digital Health, for instance, as well, about their plans in terms of, okay, how much data can be made transparent. So obviously that has to be balanced with information governance, anonymity considerations. The one thing I'd just like to touch on, Sarah said about code, and one crucial phrase she used, in the community. And that's where I'm personally quite a strong believer about caution with transparency on code, and ensuring it's only available to suitable, qualified professionals to a degree, because otherwise it can actually be more dangerous than useful in the wrong hands. But someone potentially in a different locality who has missing data, for instance, that the code doesn't take account for, utilizing that could be more harmful than good. But I think we're all progressing in terms of the right direction with transparency, and hopefully we'll get there.
Thanks, Adrian. And one of the things I'd add to what's come earlier in the discussion is that I think the transparency is a sort of necessary but not sufficient step, because there's a difference between sort of dumping a kind of personal working code or document or even data set in a kind of non-indexed URL somewhere, or a sort of big long listed database that's very difficult to navigate, whereas actually something that people can sort of search and find, others can discover, and that is kind of annotated and presented in a way that people can pick it up. I would argue that kind of code that only makes sense to the individual who wrote it and is sort of buried somewhere in GitHub isn't actually transparent. It's not really open. So one of the things that came up in a question was about whether we're seeing practices change in that regard. So just very quickly from each of you, do you think you're seeing a sort of cultural shift when it comes to openness? Starting with Blythe again.
I think with the COVID pandemic, we're absolutely seeing a huge cultural change all over the world. You know, I think some of it is in response to many of the, the processes and red tape that was instituted for very good, purposeful reasons. It takes a long time to go through to access a lot of data sets and understand what was done in analysis. And so even seeing in a national emergency, knowing that, we need to generate evidence as fast as we can and be able to communicate uncertainty about it, and even making results available in preprints online. I think that there are many tools that have always been available to us, but were not necessarily like fully accepted by the scientific community, that now there's a big wave of use that many people are understanding more clearly now the strengths and the weaknesses.
Great, thanks. Sarah?
I think we are getting there. I think it is getting better slowly from those that work in data and analytical roles. Where I have seen the appetite for openness and interest in data expand massively is actually with the general public off the back of this pandemic. The conversations that people are having in their everyday life about the data visualizations and statistics, I think is really telling.
Brilliant, thanks, Sarah. And then Adrian?
Yes, completely agree with that, Sarah. I think that I touched on this in my opening remarks as well, that there's a lot of lessons learned from the pandemic, but at the same time, I think we should actually ensure researchers, data controllers, in industry, we do also celebrate some of the successes we've had, and particularly mobilizing and really helping the public during this difficult time. But then on data, what I think we will return in the new world to this social contract around data being absolutely crucial, and therefore again transparency is so key to that. The empowered patient, building on what Sarah just said, that they've now had their appetite whetted. They'll want to know more about how their own data, hopefully, and that's again the cultural change we'll see with the public and patients. And again, we'll suddenly have to be the ones explaining what, say, broken time series mean because of the virus pandemic. So there's still a lot of hard work ahead.
Sure thing. Thanks, everyone. So I'm going to flip the order a little bit and start with Adrian next, because you mentioned this next question or referred to it in your opening remarks. So there's a question about how we can scale up, and whether scaling up means different data sets, different organizations, different modalities, and kind of insert other dimensions we could scale up here. So you mentioned, and it'd be great to hear from all of you, but we'll start with Adrian, because you mentioned that in your strategy, sort of scaling up this work and data improvement is one of the key parts. So what does that look like, and how do we do that?
So from my point of view, Ben, I'd just like to re-emphasize that this has to be systematic with all the different stakeholders involved, and that's where NICE will do its bit in terms of methodology and standards to help ensure that scaling up. But we're so dependent on all the other players around us, from NHSX on professionalisation, the national data strategy here, to the work from industry, bit like Flatiron, IQVIA, others. We all need to be moving forward the evolution across that whole ecosystem, as I touched on.
Sarah, what do you think?
Yeah, I have to agree that it needs to be a whole system approach, and we all need to be playing our part. It would be almost, this is more of a personal opinion than one of that of NHSX, but it would be great to get to a point where there's almost like a charter or something that we could sign up to that sort of says, you know, if we're going to be using data, these are the things that we're going to do in return for being able to use that data, or, you know, if I'm going to hold data, these are the things that I agree to do to ensure that the value is being got from it value to the public and to patients.
So sort of going beyond principles on reuse of data, it's a sort of contribution to the improvement of it as part of the work, so that baking that in to mean that it happens across the board.
Exactly.
It's interesting. And Blythe, what are your thoughts?
You know, I'm just thinking about what an incredible competitive advantage the UK has compared to countries with fragmented healthcare payers. You know, in the United States, we have no, you know, unique identifier for patients. And so even today, to hear the astounding things that have been done, you know, linking together many of your data sets, whether it's, you know, COVID test results to patient charts. You know, I'm just astounded at the opportunity that you have to answer questions at scale that are not possible to answer in other countries.
Thanks, Blythe. And if we could just hold that thought, you mentioned there about some of the differences between the US and the UK. And we've got a question in on the chat about how approaches translate across different countries. So what's the same and what's different? So I'll ask you first, and then we'll invite the other panel members.
Yes, that's such a good question. You know, I think a lot about representativeness, transferability, you know, portability of results. You know, in what situations can we learn from US patients and then pick up those results and drop them in another country and assume that the estimates will be the same. And we even saw this with in the pandemic. There were often in both the US and the UK significant racial disparities in outcomes for patients. Yet when we look at, you know, socioeconomic differences and disparities, the root causes of those healthcare disparities, I think, can come from different sources. So there are many times where even, you know, especially when healthcare guidelines and treatment guidelines differ between two countries, it becomes less and less valid to be able to pick up estimates from one country and assume that you'll be able to get the same health benefits in another country, depending on what their, you know, given standard of care is. So I think that there's a lot we can learn from using the clinical depth and large numbers of patients in electronic health records to understand, for example, treatment heterogeneity. You know, what's the individual person level treatment effect that we expect for this? And can that then better inform the benefits that we would expect to see in patients in other countries? So I think that we're, you know, at the beginning probably of robust research that's going to probably come in the next decade, equipping us with how we can do that better.
Brilliant. Thank you. Sarah or Adrian, any thoughts or anything to add on international transferability?
So it's interesting that Blythe it looks on at the systems that we have in the UK, because equally we could do so in the US. And yes, whilst we have the NHS and good systems, once you've actually touched the healthcare system, actually it's very difficult to then link in anything that's happening before you start interacting with the healthcare system. And actually there's good evidence to suggest that by the time you are seeking some sort of health intervention, the opportunity to avoid it has long since passed. And so the ability to link together and link in wider determinant information, which actually I think I understand you are far more likely to have on a patient in the US based on their sort of insurance records. This is something that is a lot harder to do in the UK, get that wider determinant information, that full sort of population health management approach, I suspect is harder.
Thanks, Sarah. Adrian.
Can I be slightly naughty and challenge Blythe to make the next decade, the next 2 years? But no, otherwise, I think that we're actually working with Flatiron, for instance, as an example of our learning by doing approach on understanding more about US oncology data and surrogate endpoints. And I think that that's just one example where for our methods and standards, we will absolutely be considering an international dimension. And I just reiterate the answer. It will never be one size fits all, and must be a problem-based decision.
Yeah, I think I would just add to that too, even beyond COVID, if we really want to have the power to investigate rare diseases, it may be that the number of patients within one country is too small to really understand what's going on with rare diseases. And I think that there are many situations that justify why we should collectively work together.
Thank you. And I think this touches on the points that Ottoline and Caroline brought up earlier this morning about the importance of a diversity of data, ensuring that the data that we use in research is truly representative. So I think we possibly have time for one, maybe two more questions. I think we'll start with Sarah on the next one, because again, you mentioned part of this in your opening remarks. So there's a question about the role of patients and publics in ensuring that data is acted upon. So how we work collaboratively to make sure that that data is actually used and that the insights that come from it are used more widely.
So yeah, this is a really interesting question, and often when we think about using data, we do typically think of perhaps researchers and analysts, perhaps clinicians, but absolutely the public and patients are key users of data and should be considered up there when data is being prepared and published. I almost think it would be an ideal situation where if you're going to publish data, it should almost be published in 3 different formats of increasing granularity, with the sort of the top level being a very neat visualization. And so all the different steps that you need to go through as an analyst or a researcher to work with data, it absolutely applies to the public as well. Can they find the data in the first place? Do they know it even exists? When they do, can they access it? Is it in the appropriate format for them to use it? Can they actually learn anything from that data? Is it in the context that's relevant to them? And then can they actually apply and share that learning more broadly, so that it's not just pockets of particular members of the public who perhaps have an appreciation for data where others don't. And I think all of these things need to be in place for them to be used well and acted upon.
Sarah. Adrian, then Blythe, anything to add?
Sure. I think I bring it right back to the poll and cultural change, and the patient's so important in terms of that continuous improvement, the snowballing and momentum effect. And as I touched on in our Q&A, the empowered patient, the personalized patient care that I think we're heading towards. But I'd also add that we will in NICE certainly be making greater use of longer term patient outcome data, patient experience data that we've not necessarily been able to use before. So yeah, I think that'll be incredibly important moving forward, and again demonstrating back to the public how important their data is.
Great, thanks, Adrian. And finally, Blythe.
I just echo what Sarah said about the importance of communicating results and making them useful to all different types of users. And, Adrian is speaking about the dream we've all had. We have electronic medical records. We should be able to have a learning healthcare system. And if in the past, we've had researchers take data cuts that are 2 years old, 2 years stale, takes them a year to fit the fanciest machine learning model and then 2 years to publish that manuscript on it. Often when it's ready to be implemented in the field, those patients that initially informed and trained that model are often long dead and can't benefit themselves from all of this great work. And so, I think that we have a future where with a rapid learning healthcare platform, where we can be learning and generating evidence in real time that can then be delivered at the point of care, like Sarah said, in formats that are useful for that shared decision making between patients and physicians to get better outcomes from patients that are contributing data. They are immediately able to benefit from it.
Yeah, thanks, everyone. And sort of fitting to have that question, because one of the panel members we'd hoped to have was a patient and public representative from one of our health data research hubs who would be talking about the work that they were doing to support the use and improvement of data. So certainly is an important aspect of this. Lots of other questions coming through. We could talk for another 45 minutes on this, but you need a chance to get a break. So I just want to say thank you to each of the panelists for taking the time to talk through, to share their views and engage in this session. So we've got a break now in the day. Coming back at 2:30 for the plenary session on Federation and Look to the Future. There'll be links in the brochure or on the URL displayed. So with that, thanks for joining and thanks for engaging, and see you in the other sessions.